We can and we must change. That was the simple message that came through in reviewing a number of root cause analyses in which inconsistent and incomplete communication contributed to a number of near misses in patient care morbidities. We are an organization dedicated to providing the best care possible to our patients, a care predicated on every caregiver having a complete understanding of a patient's medical condition and their treatment goals. This is something we were not doing and always achieving and needed to change. So began our journey into this process of improving handoff communication. We stepped back and we looked at our current process, what it looked like, an observational study, and what it felt like to our caregivers, a survey. You'll see those results in a few minutes, but the short answer is not very well. A big opportunity to improve. We then looked at the tools that might be available to help us achieve our goal, ultimately settling on an SBAR tool, a tool developed outside of healthcare, but elegant in its simplicity. SBAR, or Situation, Background, Assessment, and Recommendation, allowed for an efficient transfer of important patient information. We can do better. In this video, you will see some background information, an introduction into the SBAR tool, and an example of its application in our handoff environment. As you watch this, I think each of you will recognize the potential dangers in our current situation, as well as the opportunities for improvement in standardizing our process of handoff communication.
Post-operative handoff report takes place in an environment that is event-driven, time-pressured, and prone to concurrent distractions while the patient is in an at-risk state. The reality of handoff report is that it is often hurried, happening while multitasking, and involves the exchange of limited information given by memory as seen in this vignette.
Hey Ann, how are you?
Hey Patty, good. How are you?
You guys look so busy back here.
We are busy.
It's crazy in the hour right now. I heard you tried that new restaurant last night.
We did. It was so much
Oh
fun.
my gosh,
So much
that's
fun.
great.
Yeah.
Well, this is Mrs. Brown. She had surgery
Oh,
with Dr. Smith.
I'm not taking care of the patient.
Oh, okay, well she
Karen,
had a
who just happened?
hysterectomy, had some morphine, some Zofran on her 4th bag of fluid. She did really well. Okay.
Here you go, Karen. There's some equipment over there for you.
Oh, thanks. Ann, did you catch any of that?
No, I didn't. I wasn't listening.
Well, I'll look on the computer. Just checking your temperature, you're just waking up from surgery.
Handoff communication, standardizing post-procedural interactions. Here at Sparrow, the patient needs must always come first. Each year, Sparrow Health System performs over 20,000 surgeries. This volume of patients allows many opportunities to greatly improve communication among providers. The objectives of this presentation are to define handoff communication, describe current handoff practices, discuss the effect handoff communication has on patient care, identify goals of handoff communication, and to describe SBAR handoff communication principles. Communication, we'd say that it is the process that ensures caregivers communicate the essential information to deliver care to a patient in a standardized process while allowing the opportunity to ask questions for clarification and check for understanding regarding the patient's needs. Handoff communication is a high-risk process that occurs in multiple settings. For the purpose of this video, we will be focusing on post-operative handoff communications between the OR and the PACU. There are variations in the way that people communicate during the handoff report. During the research, we observed the ways in which handoff was being performed in both the Newman and West PACUs. Observations demonstrated that sometimes report consisted of multiple interruptions, multiple receivers, minimal patient information, inefficiencies in documentation, and report was often provided from memory. As you can imagine, poor communication can have many negative effects on patient care. In fact, the clinical communication errors are the leading cause of sentinel events. A root cause analysis focuses on systems, not to find fault in individuals. Initial survey results indicated that over 84% of staff can recall at least one time where vital patient information was missing from the handoff report in the past year. 27% of staff can recall at least one instance where inaccurate information at handoff led to a near-miss event or direct patient harm. 83% are willing to adopt a standardized method of handoff report. There are several best practice handoff goals. These include a quiet location with minimized interruptions, standardized format for handoff communication, important information given up front, pause for clarifications and/or questions, slow down, repeat important information. PDCA model for continuous quality improvement was utilized to find an effective means for improving and standardizing the handoff communication within the health system. SBAR is a communication tool that is used to standardize information transfer. It accounts for the situation, background, assessment, and recommendations. The situation includes the name of the patient, their date of birth, and the name of the operative procedure. The background specifies the type of anesthesia administered, intraoperative medications, and the IV fluids that were administered. Additionally, blood loss, surgical site findings such as dressings, tubes, drains, or packings, and any significant OR events should be noted in this section. The assessment section includes findings such as hemodynamic stability, airway and oxygenation status, thermal status, and urine output. The presence or absence of surgical complications, level of pain, and method of pain management should also be addressed. The recommendation section allows the staff an opportunity to inform PACU personnel of any anticipated interventions that will be performed in PACU. It also ensures that immediate post-operative orders have been completed and allows time for questions to be asked or concerns to be addressed. SBAR communication is a useful tool that can help organize and standardize handoff. It integrates and summarizes relevant information that should be included in a handoff. Having a better handoff tool can actually reduce the overall time that the patient spends in PACU. The tool can be modified to include all relevant information necessary to each patient's care. The SBAR communication tool has been integrated into the EMR, allowing ease for providing a standardized and comprehensive handoff report. Ideally, the following sequence should be utilized when giving the SBAR report. First, settle the patient and apply the necessary monitors as a team. Ensure that the patient is stable. Once both sender and receiver of the patient care are ready to begin, the verbal report should be followed, going through each section of the SBAR. Use the Epic screen as needed for reminders. Allow the entire report to be given before asking questions, as the question may be addressed during the report. Finish the report with a clear closing statement, such as, "The handoff report is now complete. Do you have any questions?" At this point, the PACU nurse should ask any pertinent questions.
In the following vignette, you will see an example of a report using the SBAR handoff. You will notice that there are minimal interruptions, each role provides specific patient information, there is an opportunity for the receiving RN to ask questions, and there is a clear ending to the handoff.
I'm just going to get all your monitors placed here.
Are you going to be taking care of this patient?
No, I'm just helping to settle. Cindy will be right in.
Okay.
Put that in.
All right. Just gonna put the blood pressure cuff on your arm. And Cindy's here.
Just get your first set of vitals. How you feeling?
And clear.
Great. You ready for a report?
Yes.
I'm going to pull up the SBAR handoff too on the computer.
This is Mrs. Brown. Her birth date is 9/21/482. She is a 66-year-old patient of Dr. Decent. She had a total abdominal hysterectomy today.
Okay.
The dressing is dry and intact. The incision was closed with suture and then an ABD and tape was placed for dressing. She has a Foley, but there are no other drains to note. Mrs. Brown is hard of hearing and she was very anxious before the procedure. She has a small Band-Aid on her right upper arm from a laceration with an incident yesterday that she had at home. And there's a little redness on her right thigh, so that is beginning to diminish, but you might want to check it.
Okay.
Okay. Mrs. Brown received general anesthesia with an endotracheal tube and received a tap block after induction for pain. She's experiencing some postmenopausal bleeding for the past 3 months, and she has no known allergies. She has a medical history of hypertension, and it's controlled with medication. She's also on a beta blocker and did receive her medication this morning.
Okay.
She has COPD, and it's well controlled with an inhaler. She was in easy intubation, and her muscle relaxation was reversed. She's received 3 liters of LR during her surgery, and her 4th bag is hanging now. She had approximately 200 milliliters of blood loss. Skin temp has been around 37 for the entire procedure, and she has a Foley that was placed intraoperatively and drained 300 milliliters of clear urine, and the bag was emptied before transfer.
Okay.
She had a total of 100 mics of fentanyl and was given 1 gram of Affirmative at 9 a.m. She's comfortable, so I haven't had to redose any of her narcotics. She also has a history of post-op nausea and vomiting with Decadron and Zofran that were given, and she has a baseline blood pressure in the 90s over 60s, and she's hemodynamically stable throughout, and no complications occurred intraoperatively.
Okay.
I'd suggest that you keep her on the 3 liters of oxygen because of her COPD. Do you have any questions?
What time should the next dose of Affirmative be given?
It should be given around 3 p.m. Do you have any other questions before we go?
No, I'm all set.
Okay, handoff is complete.
Mrs. Brown, are you having any pain?
Yeah.
What number would you give it on a 0 to 10 scale? 0 is no pain and 10 is the worst possible.
Like a 5.
Would you like some pain medicine for that?
Yeah.
Okay. Any nausea at this time?
Yeah, a little.
Okay. And you have no allergies, correct?
That's correct.
Okay. We'll get you some medicines to make you more comfortable.
We can and we will change. Simple words, but powerful when applied to something like the implementation of an SBAR tool in improving the handoff communication of our patients. The 2 vignettes you watch contrasted markedly the difference between a disorganized, unfocused, and incomplete transfer of information, and one characterized by structure, patient-centered, focus, and a comprehensive transfer of that important information from caregiver to caregiver at a critical time in a patient's care. I'm excited about this change, and I hope as you watch this and think about this, you will be too. This is an opportunity for each of us to reach for that level of excellence in healthcare that we as a group and we as an institution are dedicated to providing. Together, with each of us engaged in this process, we can do just that, improving safety and ensuring the best in care for our patients.